Studies have shown that some cells and some organs of both humans and animals are highly sensitive to radiation. Which cells and which organs can be most affected? X-rays, how safe? We'll answer those questions on today's Consultation. The University of Illinois at the Medical Center Chicago brings you another program in this series and made possible in part by a grant from G.D. Searle and Company. Our guests from the Food and Drug Administration are Dr. William Cole, Associate Director, Bureau of Radiological Health, Rockville, Maryland, and Mr. John Vilforth, Director, Bureau of Radiological Health, Rockville, Maryland. Moderator for this program is Jack Righeimer.
Welcome once again to Consultation. Fascinating program. I think one all of us are going to be very interested in, or should be. If any of us have ever had X-rays in the past year or so, this is a show which is going to talk about that subject. As you heard, X-rays, how safe? Gentlemen, thank you for coming from the Federal Drug Administration. We appreciate it. Mr. Vilforth, let's X-rays, talking about the broad subject of X-rays, that's very, very broad. What specifically are we going to be talking about today?
Well, as you know, X-rays have been around for a long time, and radiation has been with us in industry and university training programs and educational efforts. But I think the most important area of radiation that we could talk about, the most interest to the public, is the one that concerns radiation in the healing arts, X-rays used in diagnosis. This is a fascinating subject, one in which I think many of our listeners perhaps would appreciate understanding a little more about it. And I'd like to focus in on that particular subject, diagnostic X-rays.
We'll talk about the medical aspect and the dental aspect.
Right, that's correct, medical and dental.
Okay. Could you define for us, we always do this on Consultation, could you define for us what is radiation?
Well, it's always a difficult subject to define, but in its simplest form, I think we can say that radiation is a form of energy in motion. And this energy in motion, when it passes through living material, the cells in our body, has the ability to affect these cells, either rearrange them, cause changes in the structure of the cell, or possibly kill the cell. And depending on the amount of radiation, quantity of radiation, and the particular organs that are involved, the radiation can do various biological effects, and we all have different susceptibilities in response to this radiation.
So we're saying each person could relate differently to different radiations, too.
Depending on the organs that are involved and the amount of radiation, yes.
Okay. Dr. Cole, as Mr. Vilforth said, X-rays, medical X-rays, dental X-rays, this has been a thing with us. It's been with us for years and years and years and years and years, and nobody really questioned whether there were any, in quotes, side effects, bad effects. Why all of a sudden are we concerned?
Well, Jack, we are concerned because in 1970, 108 million people had one X-ray or more during that particular year. And as Mr. Vilforth said, X-rays can produce some damage to the body. And we divide this damage when it is produced, and the risk is really minimal, into what we call genetic effects. The genetic effects are those that will show up in subsequent generations. The ones that are of concern to the individual undergoing the X-ray examination we call somatic effects. These affects the body itself. For example, a woman undergoing an X-ray examination who is pregnant, the unborn child is more sensitive to radiation than, say, the mother herself. We are concerned about this type of X-ray examination. We know that cells are damaged by radiation, but we also know that cells recover some of their viability again, some of their normal existence after the radiation. One of the things that really bothers us most of all is what is the effect of low-level radiation? That is, the type of radiation that we get from the background, and in particular from repeated X-ray examinations over the years. We really don't know what the long-term effect of this low-level radiation is. For example, the question of possible damage came up when Dr. Rankin first discovered this modality, when he must have had some concern about possible damage, because the first X-ray film that was made was the film of his wife's hand rather than of his own.
Well, didn't even take a chance himself, huh?
I guess not. I guess he decided that he would have his wife's hand show up first.
Now, I can understand with when you mentioned using the example of a pregnant lady going in and having an X-ray because of the unborn child. Are we saying there are certain parts of the body, certain organs within the body which can take X-rays better than other parts? Therefore, you can X-ray your elbow 40 times more than you could your liver. I don't know. I'm just using an example.
That's right, Jack. Certain areas and certain cells of the body are more radiosensitive, that is, are damaged more easily and with less amount of radiation than others. For example, we believe that the reproductive organs, or the gonads it's called, are more sensitive to the effects of radiation than, say, the skin, for example. That doesn't mean that the skin is not sensitive to radiation, but less sensitive, let's say. The fetus, as I mentioned a moment ago, is certainly more sensitive to radiation, and at certain stages of the pregnancy. In the first 3 months, we feel that the sensitivity is greater than it is in the last 3 months.
I think generally, Bill, we can say that the more rapid growing cells are the ones that are more sensitive to radiation. This is why the skin is perhaps less sensitive than the blood supply system, which is a rapidly growing and reproducing system.
Because we do get radiation from the sun,
right.
don't we? Natural radiation
Yes.
we get.
We speak of that as background radiation, Jack. We really live in a sea of radiation to some extent. But today, of course, we are concerned about medical radiation. The second type of tissue that we are concerned about is the bone marrow, where the red cells and the white cells are actually manufactured. The most sensitive cell, I believe, is the white cell. This is the cell that really protects us against infection. The thyroid gland in the neck is another gland that we feel is more sensitive than other tissues. For example, we are concerned that the so-called annual routine full mouth X-ray of the teeth is possibly could expose the thyroid gland, and we are concerned about that. And the lens of the eye is another organ that we are concerned about. It may be more sensitive than other tissues. So that's about the difference in radiosensitivity.
Okay, so there it is. So it's important to know the part of the body that you are really X-raying and how often you should X-ray that particular part of the body.
Yes, we think that every effort should be made to protect the reproductive organs in any type of X-ray examination. And this is very simply done by the use of lead shields and the use of a proper technique, which we'll discuss a little later.
Okay. Now, you've been giving a case about the badness of X-rays, but X-rays must be good because we've had them a long time and they do a wonderful thing as far as diagnosis is concerned. So you better give the other side a little bit, too.
Well, I'm glad you asked that question, Jack, because I personally feel that the benefits far outweigh the risk of this diagnostic test, for example. It's been calculated that 70 to 80% of all the diagnoses that are made in the United States today, either in the hospital or in a doctor's office, are made or confirmed by the use of X-ray examinations. For example, it would be impossible to do any type of setting of fractures, for example, without this modality.
Sure.
We calculate, and I saw this in one of our journals, that there will be 50,000 skiers who will have a fracture this year. This is just a small sample of the number of fracture cases that we see every year. Without X-ray, it would be impossible to do and get a good result.
There's an element of hazard, Jack, I think that I'd like to mention, and that is the risk element of radiation. And this is very difficult to quantitate, but I think perhaps if I were to use the analogy with cigarette smoking, perhaps the viewers would appreciate this. For example, we know that radiation produces cancers, leukemias. It also will shorten our lifespan. And we know that, for example, cigarettes will increase the risk to cancer, about the cancer of the lungs. Now, like cigarettes, we know that if like in smoking cigarettes, we know that if we smoke a certain amount, we may or may not get lung cancer. It's a risk. It's a risk that we, perhaps if we're smokers, are willing to take. Radiation risk is much the same way, only the risk in this case may be imposed upon us by the physician or the clinician. But the risks are statistical or probabilistic, as we say. Mm-hmm. For example, the amount of radiation that we might receive from medical radiation perhaps could increase the incidence of certain diseases by maybe 1 in 10,000. That is, if 10,000 people were to receive this particular X-ray, perhaps one might receive an increased, one might receive a particular disease, a particular type of cancer. This is the order of magnitude, and these are not specifics. But now if you look at the number of people in the United States receiving X-rays, and practically all of us, almost all 200 million of us get it sooner or later, this means that, well, 1 in 10,000 times 200 million, it means that there's probably about 20,000 people in the United States who may be getting that particular disease or illness, you see, as a result of the radiation. Whereas you, as an individual, may only receive or have a probable chance of 1 in 10,000, which is a reasonable risk if you have a broken leg and or a skier, as Dr. Cole talked about. But when you use the total population of the United States, that means there are perhaps 10, 20, or more thousand people with some sort of disease or illness, perhaps caused by this radiation, that need to be treated. And I think that our job in the Bureau of Radiological Health, the Food and Drug Administration, along with our colleagues in the state health departments and in our colleagues in the profession, is to do the best job we can to keep the exposure from these radiations as low as possible so that the risk is reduced. For example, if we could reduce the dose to half of what it is today, we perhaps could cut that risk from 1 in 10,000 to 1 in 20,000. Instead of 20,000 people in the United States, maybe there's 10,000. In other words, a saving of life or cancers of maybe 10,000 per year.
Yeah, it is. Right, X-ray now has become a two-edged sword, good and bad. And it's up to an agency like yours, the Federal Drug Administration, to protect us, the consumer.
Right.
That's your job. I can't do that, you know. It's up to you to, because I'm not qualified in that area to do something.
Jack, another example of what I consider a real benefit is in the use of pelvimetry. Pelvimetry is an X-ray examination that is done on a pregnant woman to find out whether or not she will be able to deliver the baby normally. Some years ago, this was done in approximately 20% of all the women that entered the general hospitals. Today, that is less than 5%. So we feel that our efforts to educate the possible risk to the fetus have gone across, that this examination is now used in less than 5%. And also the physicians that ordering this examination, when it is really necessary for the safety and health of the child and the mother, that we have advised that they have this done in the last 3 months of the pregnancy, because as I mentioned before, the fetus is less sensitive at that stage.
We're becoming more sophisticated about X-rays and where they can be used, when they can be used, why they can be used, and how they can be used. That's as simple as that.
Right.
You used a term, and I think you better explain it. Low levels, high levels, and all, and I'm a little confused. You said we're more concerned about low level. I would think you'd be more concerned about high level.
Well, low-level radiation, as I mentioned, Jack, concerns with the type of X-ray examinations we're discussing today, the diagnostic type of X-ray examinations. This is low-level radiation.
Oh, I see.
Now, if we use, semantics. Right. If we use X-ray in therapy or treatment of disease, this is considered high-level radiation. Cobalt, for example, right, and where the dose is measured in thousands of rads, which is a term used of the absorbed dose. So we're talking about two different things.
Okay. The way I assume the publican can, the public, we, the consumer, can get the minimum of risk and have the most to benefit is by listening to and hoping that which you are doing with the federal agencies like yours, the FDA, is involved in working with the physicians and radiologists so that we will have a safer X-ray.
Our main reason for existence is to reduce the unproductive quantity of X radiation and optimize or get the most benefit out of the radiation that's used in diagnosis.
Jack, if I could have that first slide, I think I might make a point here on, I think, of the benefits.
Okay.
Now, there are 3 parts to this. The first is the sound medical judgment. The second is good radiographic technique. And the third is X-ray equipment. I will discuss the medical judgment and leave the other 2 up to Mr. Bilforth. Now, in the taking of an X-ray, a judgment has to be made by the patient's physician as to whether or not this examination is indicated.
If it's necessary, yeah.
Is it necessary? Correct. This is determined by the physician's experience, by his education in medical school, by efforts of agencies similar to our own, as to what are the indications for this particular type of examination. So the first decision that is made when an examination is to be done is made by the referring physician. And we call this medical judgment. The type of examination that we don't like to see is when an X-ray examination is done in a sense by or ordered by a physician to protect himself for possible litigation at a subsequent time. The exact number of these cases, how many of them are done in a year, is not really known, but we know that it is really too high. This is particularly true in very sensitive type of fractures.
Mm-hmm. So in other words, what you're saying, it's up to the physician's responsibility to say that X-ray is important to have because I have to find out whether or not this really is the problem.
That's right, but as I said, all too frequently, he feels that if he doesn't repeat this examination at certain, maybe too frequent intervals, such as a fracture of an ankle in a cast, that it's possible that maybe something will slip and he later might be up for possible malpractice or litigation. So too frequently, these examinations are ordered for that purpose. This, in our opinion, is unnecessary.
Okay. I don't want people going to their physicians and have the broken leg and he took 2 X-rays and Dr. Cole said, "Hey, you only should have taken 1." We've got to clarify that. There may be a reason for taking the second X-ray too.
Right.
That we're just saying that is if that is in the intention, the mind of the physician, that's not the proper way of using X-rays.
That's correct. Another one that we worry about too is when a patient or an individual makes a decision himself to have an X-ray examination. We call this self-referral. For example, if an individual sees in the parking lot of the shopping centers the TB vans, he might be tempted to go in and have an X-ray examination of his chest, when actually there's really no indication that this should be done. We feel that only this type of examination should be done is when there is a sound medical indication.
Okay. Your physician orders the fact that you need a chest X-ray.
I think it's
That's
important, Dr. Cole, to point out that these changes in judgmental factors are coming about mainly through the work of the professions. They're involving the educational institutions to incorporate these changes. And you may mention a bit about the pediatric fluoroscopy. I think this is a rather dramatic example of changes that have taken place.
Very good, John. Some years ago, Jack, it was almost a routine for a pediatrician to fluoroscope a child or an infant on the table, just to check the size of the heart, to check the expansion of the lungs. Well,
excuse me, I might interject that fluoroscopy is much higher, delivers a much higher exposure to the individual than just regular radiography.
Okay.
So this is quite concerned when fluoroscopy would be used.
this was brought to the attention of the pediatricians, and it was cranked back into the medical school level, that just what can you obtain from this type of examination using the fluoroscope. And subsequently, the American Academy of Pediatrics issued a statement cautioning all pediatricians to only use this when it is absolutely indicated, and where possible, to use a X-ray film examination where the dose is much less than it is with the fluoroscope. So it's this type of thing that we think through education that we are making our point.
For all of us to be more and more educated. I got to get to the technician.
I was going to say this ties in very nicely to the question of technique, because we're talking also about technique and judgment that were used in this particular procedure.
What happens, if my, the physician makes a proper judgment, and we're going on an assumption because I'm with physicians all the time, therefore they make proper judgment, and they go on, and my technician maybe zaps me a little bit too much. That's a possibility, I don't know. How do I know?
It's sort of like you're deciding to take a picture of your child with your camera, and that's your first judgment. The second point of technique, you find out you left the lens cap on the camera, or you have to retake the film. So our concern here is that the individuals who are actually adjusting the machine, making the settings on the machine, and processing the film, use the best information to get the best quality radiograph. And all too frequently, we find that there's much room for improvement. You see, there's probably 100,000 technologists or technicians in the country who are responsible for taking the X-rays. Most of these are not physicians; they're technicians, and there's no real requirement of education for these. Only 3 states in this right now have any sort of licensure laws for these individuals.
Wonderful.
This means that in many cases the individual may walk in off the street and be activating the machine. So our concern is, and one of the things we've been doing in the Bureau of Radiological Health has been to place attention at the educational levels, continuing educational levels, working with the states and the state societies of technologists to improve this, yes. There are certain things that we would emphasize. For example, making the proper selection settings on the machine, just like in your camera. You've got to, if you decide to take a picture, you've got to make the proper adjustments, or the exposure's incorrect. And if the exposure's incorrect, that may mean the film would have to be taken over again. The picture would have to be taken over again. Secondly, like in photography, if the film isn't processed properly, you may also have an ineffective picture.
So you're upgrading, actually.
Yes, and then thirdly, is another interesting area, it's a process we call collimation. Collimation is that device or mechanism that we use which limits the X-ray beam to just the size of the film. Now, if I could have the first slide, I think that you'll be able to see that on that slide, the top picture shows what we facetiously call wall-to-wall radiography, where the technician does not bother to make the proper adjustments of his X-ray beam, and the beam covers all of the vital organs of the body, and in addition to the film. And of course, that radiation which doesn't strike the film not only destroys some of the quality of the film, but also has a risk of biological damage. So what we try to encourage is the technician to restrict the area of the beam to the same size of the film, as shown in the bottom slide.
Right. In other words, just that point you want to X-ray.
Right.
Using your same analogy, I go a little further about the camera and so forth. What if my camera is lumped up? In this case, what if the equipment is lumped up?
Well, that's the third point in the list of the three that we had on our first slide, and I think this is extremely important because here is an area where we have made some considerable progress over the past few years. And I say we, I mean both the Bureau of Radiological Health, but perhaps more significantly our colleagues in the state radiological health programs, and certainly our colleagues in the profession, because here we can really place a lot of credit for the improvement. The equipment has been inspected in most cases and is being inspected to date by the state. The federal government has no authority to inspect equipment in physicians' offices. Now, what we do have under the recently passed Radiation Control for Health and Safety Act is the ability to set performance standards for new equipment. And we have established performance standards. These were published in August of 1972, and will be effective for all new X-ray machines being manufactured after August 1974. This means all the X-ray equipment must meet certain performance standards. And if I make a mention of the previous slide of collimation, we have incorporated into this performance standard a requirement that this type of collimation be mandatory for new equipment, so that we hope that we will eliminate all of the extraneous radiation that was shown in the top of the previous slide.
So what you're saying, really, gentlemen, is the fact that now you made a case for X-rays and the problems of X-rays, and the fact that there is some danger, but we're working towards the right end, and things are becoming much better, and you're having certain protective devices employed so that we, the public, shouldn't be that scared. I don't want people to go around being scared. And one way we can stop them from being scared, too, besides listening to this program, I have some material I can give away, and not I, but the Federal Drug Administration is so happy to give this away. I don't know if you can see this. It's called, oh, that's good, Jack. Flare that right up. Radiology Health Protection and Consumer Radiation Protection. I'll be most happy to send both to you, if you will write to us, in care of Consultation, University of Illinois Office of Public Information, Post Office Box 6998, Chicago 60680. And you can get both copies of these two pamphlets. We'll give you an idea of what is going on and what your FDA is doing for you and why they're doing it. We only have about 3 minutes left, gentlemen, and that's the reason I thought I just wanted to say, kind of sum up a little bit at the end there, saying that, you in the beginning, kind of made a case to scare the heck out of all of us that X-ray is coming and we're going to be worried about this and vital organs, and then you went on. It was very good. You kind of refuted a lot of the things along the way.
There's no question about the beneficial effects of radiation, of diagnostic X-rays, as Dr. Cole indicated. And the trend in the future is going to be, I'm sure, greater. Our data from the studies that we've done show that the increased radiation is being used at ever-increasing amounts, and hopefully for the betterment of mankind. But at the same time, we must be concerned about this element of risk. And I think if I had one point I would like the viewers to appreciate, it's the fact that we do have an effective program, we do have an agency at the federal level, and most of the states are involved at the state level in doing something about this, keeping this into perspective. We also are working with the professional groups to bring the excessive amount of radiation under some degree of control, and I think we can be rather proud of the accomplishments that have been made to date.
Just one quick question, Dr. Cole. You indicated something about the mobile X-ray. It is not a good thing for us as individuals to go in and select and say, I want to, chest X-ray. This should be left up to your physician, should it not?
Jack, the dynamics of tuberculosis have changed over the last 25 to 30 years, and in some areas of the country, tuberculosis is almost non-existent. And it's for this reason that people who themselves walk into these vans and have an X-ray examination, we think this is unnecessary X-ray exposure of that individual. And we issued a policy statement in February of this year recommending that this type of X-ray surveys of the general population be discontinued. Now, the National Tuberculosis and Respiratory Disease Association in New York came out with the same policy statement. So, in a sense, we are recommended that this type of survey be discontinued.
I think it's also important to point out to the viewers that generally the type of equipment that's used in these vans results in much higher exposure than the same kind of a procedure used in a hospital or a physician's office, perhaps as much as 10 to 100 times more exposure than you would get for the same type of diagnostic procedure in an office, just by the nature of the equipment that's used in these mobile units.
That gets back to your 3 points.
Exactly,
The physician,
exactly.
The judgment, and
Judgment.
the type of equipment
Right.
used, and the technician. And
All of
I
these
think
come
that's important.
together.
Gentlemen, thank you very much. I want to thank you, ladies and gentlemen, who watched Consultation. I hope you've learned something from this, know a little bit more about X-rays. Till we see you again on Consultation, the best of health.
X-rays, How Safe, has been a program in the series Consultation, presented by the University of Illinois at the Medical Center, Chicago, and made possible in part by a grant from G.D. Searle and Company. Our guests from the Food and Drug Administration have been Mr. John Vilforth, Director, Bureau of Radiological Health, Rockville, Maryland, and Dr. William Cole, Associate Director, Bureau of Radiological Health, Rockville, Maryland. Moderator for this series is Jack Righeimer, Coordinator of Public Service Radio and Television Programming. This is Frank Sweeney. The preceding program was planned in cooperation with the Department of Health, Education and Welfare, Food and Drug Administration.